ladies and gentlemen, supporters and members of the Neurological Foundation and our friends at our neurological community support groups. The Neurological Foundation is the only non-government neurological research funding body in New Zealand, and over 98% of our funding comes from donations from the public. Funding for brain research is needed more than ever to improve the outcomes of a growing number of New Zealanders being diagnosed with neurological disorders. As our population ages, so too does the number of these disorders, and the only way to end neurological disease is with the best research. Research, however, is making some great progress, and you'll find out today from our speaker, Dr. Jon Simcock. There are more than 1,100 known neurological disorders. Your nervous system is made up of the brain, the spinal cord, and the nerves throughout your body, and together they control all the workings of your body. When something goes wrong with a part of your nervous system, you can experience difficulty with speaking, swallowing, breathing, or learning. You can also have problems with your memory, senses, and mood. In this lecture, Neurological Foundation's medical advisor, neurologist Dr. Jon Simcock, will speak about the latest progress in the understanding of brain disorders. He'll also discuss how the 21st century has introduced exciting new neurological investigation techniques, paving the way for enhanced diagnosis and treatment. Dr. Simcock has enjoyed a long and distinguished career as a neurologist. He was born in Dunedin, educated in the New Plymouth Boys High School, and graduated from the Otago School of Medicine in 1960. He became a member of the Royal Australian College of Physicians in 1964 and completed his specialist training as a neurologist at the National Hospital for Nervous Diseases, Queen Square, London in 1968. So, please join me in welcoming Dr. Jon Simcock.
Thank you, Madeline. Most of that introduction was accurate. Very flattering, thank you. It's great to be back in Whangarei. I haven't been here for a number of years. My intense interest in the nervous system started when I did an honours degree in neurophysiology in Dunedin and completed that in 1958. And then 10 years later, as Madeline has said, I'd completed my neurology training and then returned to Auckland. And one of the institutions that I started was to do neurology clinics in Whangarei. And in 1968 there were two superb physicians here, Doctors Norman Davidson and Maurice Orpin. And it was a delight to come up here and do the clinics, which were very well organised by some of you might have remembered, Miss Audrey Kippenberger. And I would come up on the Thursday and stay overnight, go back on Friday evening. And I did that each 6 weeks for about 15 years. And then that was taken over by other neurologists. So I had a long connection with Whangarei, which I valued a lot. Now, today's talk is going to be in 3 parts. The first part is to talk about the Neurological Foundation. The second part is to talk about the progress that has happened in neurology during my professional lifetime. And I stopped seeing patients this year after 45 years in practice as a clinical neurologist. And believe me, things have changed enormously over that time, and the rate of change has increased. The final part of the talk is really to just say something of where I see the prospects in neurology and emphasise the fact that with the progress that's gone on, the progress is going to continue, and things that are really major problems now, such as Alzheimer's disease and the cause of Parkinsons, I think we're going to see effective treatment for those disorders over the next decade. The mission statement of the Neurological Foundation is to alleviate suffering from disorders of the brain and nervous system through research and education. I'll talk about these two factors, the research and the scholarship, shortly. I'd just like to mention the very important appointments that have happened in the attaining the chairs of neurology and neurosurgery. 5 years ago, we appointed Alan Barber as the Neurological Foundation Chair of Clinical Neurology at Auckland Hospital. And that's important because it bridges the gap between the research on one side of the street in the medical school, the very strong Centre for Brain Research, with a very strong Department of Neurology with 15 neurologists in the Auckland City Hospital. Similarly, the foundation raised funds for the chair in neurosurgery in Dunedin, and Dirk de Ridder has taken up this appointment earlier this year. Now, finally, there is a need for a chair in neurosurgery at Auckland, and the foundation is helping the university to raise the funds for this. Now, we have just completed one of these research grant rounds, and there are two held each year. And the purpose of these is to allocate research money. And we are now in a fortunate position of being able to fund research and education to the tune of something like $2 million a year. And this has a huge impact on neuroscience and neurology through the country. The first topic are the small project grants, and these are for startup on someone's got an idea or a technique. They want to see if it will work or can work. It's usually for about 6 months or a year and up to about $12,000. This grant round, we had 10 project applications, only 3 of them could be funded. The project grants themselves, these are by researchers, full-time researchers, usually 2 or 3 of them, and the funds go over usually between 2 and 3 years. So they are for very significant amounts. And there were 15 applications for these project grants. Each project grant is a small pile of paper, and for each project grant there are between 4 and 6 overseas experts making their comments and criticisms on them. So they've been very well assessed by overseas experts and the Scientific Advisory Committee. And 4 of those 15 projects have been funded. So it's very competitive, and the research that is funded is of a very high standard. Travel grants are really just so that people who are doing the research can present their findings at overseas meetings and meet up with their colleagues. It's a very important part of their work. I would like specifically to mention the Brain Bank. This has been set at the Neurological Foundation Brain Bank, is in the centre of brain research in Auckland, and it has provided material donated very generously by patients and, of course, their families. And there are about 150 brains in the Brain Bank, and it's continuing to provide extraordinarily useful information to researchers not just in New Zealand but around the world. Now, on the education side, we provide scholarships really right from the word go. When the summer studentships, they're doing an honours degree, they do 3 months research over summer, and then when they go on to do their PhD, they apply for Miller scholarships. We get about 15 applicants a year, 2 are awarded, and they're very highly regarded. And then, having got the PhD under their belt, they then get funded for a postdoc fellowship, and there's 1 a year of those. Now, someone like Maurice Curtis, who has come back, and he's the Assistant Director of the Brain Bank in Auckland, Maurice Curtis has had all of these awards, and he was working in Scandinavia and Sweden, and he was so promising that we said we must have him back, and got this repatriation fellowship underway, and he was the first person to get that. So he's back, and the scholarship program is very good, a very good investment. We've had so many good people. And finally, the Chapman fellowships are those for medical graduates, and I just show some of these. Jon Fink and also Alan Barber have done overseas research in stroke, come back, set up stroke units, and the standard of the management of stroke throughout the country has been improved significantly by these 2 people through the funding of their Chapman fellowships. Barry Snow is known to some of you as he's head of our movement disorder group, and spent his time in Canada, and John Reynolds was in practice here but then changed course, and he is now Associate Professor in the Department of Anatomy doing research in Dunedin. And finally, Jenny Pereira has been overseas and returned to be an expert in the field of MS. So the Chapman Fellowships, and we've got 2 at present, one doing MS research in London and the other stroke research in Melbourne, and I'm confident that they'll both come back and do good work. Now, briefly, that's just the structure of the administration, a lay council that runs the whole show, and as with everything else, the emphasis shouldn't be at the top, should it be at the bottom, with Rowley and Madeline organising all liaising with all of these CLOs. And the medical advisor just stands around and gives talks. Now, the progress in neurology that I'm talking about is my professional lifetime of 45 years. And the changes that I've selected have been for a particular reason. I can't possibly cover all of the many advances. And I'll give an example of each of these, sometimes with patients, and we'll cover these topics. And the first topic is a field that has no immediate impact, and I don't think many of you would be aware of the changes in genetics and molecular biology. But this has been a revolution over the past 20 years. And this is where we're going to see further changes in the understanding of what's going on in these disorders. And I illustrate this by talking about a patient whom I first came across when I was a registrar in Auckland Hospital in 1964, when she was 17. And since the age of 10, she'd had trouble walking, and it would be much worse in the afternoon, and her walking would be rather like that. And because it fluctuated a lot, it was regarded as being somehow psychiatric in origin, and she was in the psychiatric ward at Auckland Hospital when she was seen when I saw her with my mentor at that time, and he assessed her as having dystonia. Now that's just a sustained abnormal posture which described really what she had. And he didn't know what it was because it hadn't been described. But he made the comment, very pertinent comment, "I don't know what she has, John, but she is a very good example of the condition from which she suffers." And because you gave anti-Parkinson's treatment for dystonia, he gave her Disipel, which was not very effective in Parkinson's disease, but it made a huge difference to her, and it got her symptoms about 50% better. And then when I returned as a consultant, I saw her again, and by this time L-Dopa had become available, and she started on Sinemet, and this cured her. She had no symptoms at all, and she's now 65, and I'm in regular contact with her, and she is free of symptoms. Interesting sidelines, she had one child, and that's important because this is an inherited disorder. And at that time she was in Sydney, and guess who her obstetrician was? My older brother. Anyway, she came back to New Zealand 4 years ago, and her son, then about 18, was having treatment for depression. But on examination, he had much the same sort of abnormality as his mother, and we started him on treatment, and he's just completed his university degree. So here is a disorder that in 1968, when I started, there wasn't even a name for it. So the name for it came in 1977, and usually, you know, a condition's described first, and then someone thinks of effective treatment. Here it was, we got the treatment before we really knew what it was. And then, with the development in genetics, this familial disorder was shown to be due to a mutation of a single gene. A number of different mutations can do it, but one gene, and the brain doesn't produce enough dopamine and produces this. And then in 2009 we were able to get her genetic test done, which showed a unique mutation, and she has a large family history which we're going to be investigating. So there's an unusual situation. Not many patients that I have, I can say that I've seen over about 50 years, and even fewer that I can say that we had any effective treatment, and only a tiny minority who are grateful for it. Now, another big area of change is neuroimmunology. And when I was a medical student, you know, we thought that there was a blood-brain barrier, and you didn't really get much in the way of immunological problems in the brain. And the other thing that we thought, well, the only one that we really knew about at that stage was multiple sclerosis, and we just didn't understand that at all. And the understanding of multiple sclerosis has changed enormously in the last decade, and we're now sort of recognising different aspects of it. And one of the striking things that over the years we saw occasional patients that looked as though they had MS, but they would only have trouble with the optic nerve, one or other or both, or the spinal cord. They wouldn't get any of the other problems, and they'd get the attacks and the remissions and that sort of thing. And then it was not until 2004 that it was found that these patients had particular antibodies to a fairly common component of the surface of the nerve cells. And this is now a separate disorder, and it needs different treatment. So over the years we've separated off this Devick's disease as a definite disorder, quite separate from MS and requiring different treatment. Now, the other odd thing to me, narcolepsy was one of the strangest disorders that I saw. Narcolepsy was this usually coming on in the third decade of life, and once patients had it, it tended to persist throughout their lifetime. And this is a irresistible desire to go to sleep, and it could happen at most inopportune moments, such as Rotary meetings. And I had a chap who was going to be president of the Rotary, one of the Rotary clubs in Auckland, and he said, "I can't do it, John. I go off to sleep straight away." And so, in fact, methamphetamine helped him, and he was able to do his job in Rotary perfectly well. But it's not the irresistible desire to go to sleep. This only needs a few minutes sleep, 2 or 3, 5 minutes sleep, batteries recharged, they're okay again. And they're unable to put that off. It may happen at the meal time, face going forward into the cornflakes, that sort of thing. But it's the other things that go with it that make it interesting. They have some particular forms of hallucination. But cataplexy, he laughed so much he fell down. This is exactly what they get. An emotional stress, and they lose body tone and they collapse. And one fellow would lift his hand in anger to the children and then collapse in a heap on the floor. Of course, they were very good at provoking him. And the same guy shared an interest that I had in duck shooting. Of course, 6:30, first Saturday in May, looking around, hear the duck going around. Then he'd see them and he'd stand up and he'd collapse. So he learned to shoot sitting down. But now that's a very strange disorder. There are one or two other aspects of it too. Now, how can you think of that sort of disorder? And what it turns out to be is an immune disturbance, in other words, an inflammatory disorder that affects a small group of nerve cells on either side of the hypothalamus at the base of the brain. And that group of nerve cells produces orexin, sometimes called hypocretin, and a particular genetic makeup predisposes you to that. So we now know a lot about this disorder, and the odd thing like this, many disorders seem to have been sort of discovered, described, or categorized by two people simultaneously. And this happened, Labrador dogs may have this as an inherited disorder. And a group of researchers in France found that that was due to the change in the hypothalamus, and on the other side of the Atlantic, someone found at autopsy that these nerve cells were absent in a patient who subsequently died after having had this disorder all his life. So it was found simultaneously on each side of the Atlantic. Surprising. Now, the first autoimmune disorder affecting the nervous system that we knew about was myasthenia gravis. And that's, I have to say, not uncommon. And one of my contributions to the literature was describing myasthenia gravis in a Rarotongan pair of identical twins. So there it is, the inherited predisposition to an autoimmune disorder producing a disorder that we now can characterize very well indeed. Now, the other one that I would mention is encephalitis. When I was a lad, all encephalitis was due to some sort of infection of the brain, mostly viral, and what we now realise is that the same sort of picture can be caused by an immune reaction against some of the nerve cells. And there are at least 3 different sorts of encephalitis that have got an immune basis. Now, in Parkinson's disease, the main change occurred in 1972 when we got Madapar and Sinemet, and this really remains the mainstay of treatment for most patients with Parkinson's disease. There have been a lot of other treatments which help to some extent, but nothing like the L-DOPA contained in the Sinemet and Madapar. In 2000, we found that deep brain stimulation could help a particular group of Parkinson's disease, and now deep brain stimulation is being considered for all sorts of things, from depression, dystonic problems, essential tremor, and even depression. So deep brain stimulation is a technique that we may see more of in the future, and also the equivalent of that given from the outside, which is transcranial magnetic stimulation given in pulses and things. So you'll hear more about both those techniques over the years. Over the past 10 or 20 years, we've realised that Parkinson's disease is much more than just a movement disorder with tremor and stiffness and lack of movement, and that there are a lot of other things that go on as well, such as drop in blood pressure, which is treated with midodrine, and hallucinations, which can be treated with clozapine, so that Parkinson's disease management now is has become more complicated. However, the main thrust in Parkinson's disease has been the understanding of why those nerve cells are giving up the ghost and when they start. So that, for example, some patients get changes in sleep pattern or loss of the sense of smell 10 years or more before they develop any signs of Parkinson's. So the aim is to try and make an early diagnosis and then be able to stop the progressive loss of nerve cells that occurs from that point of time. So I can see now that we're at the point where we've got sufficient understanding and the ability to influence these cascade of steps that end up with the death of particular groups of nerve cells. So while people say, oh, you don't know anything about Alzheimer's or Parkinson's disease, we do know a lot, but it is yet to translate into effective treatment. Now, in epilepsy, one of the early helps in diagnosis was video monitoring, being able to take a video and record an EEG at the same time, and this helped characterise the type of epilepsy people had, and that would help in the treatment. The surgery for epilepsy has not really changed much over the past 20 or 30 years, and I don't see that that's going to change all that much. But the thing that is changing is our knowledge of what goes on in different types of epilepsy with genetics and what the mechanisms are for the development of epilepsy. And I think that's where we're going to see the change. Medications, 1903 there was phenobarbital, 1937, when I was born, that was when Dilantin came in. And then a major change was Tegretol, carbamazepine, in 1968. And then shortly after that was Epilim, and over the past decade there have been a whole cluster of new medications. And the problem is still that it is very hard to match up which medication is going to be best for a particular type of epilepsy and whether that medication is going to produce side effects in that patient. So it's still, unfortunately, a lot of trial and error going on. As far as stroke goes, I started off with a great interest in stroke, and at that time the diagnosis was made by putting a catheter into the femoral artery and putting it up and injecting dye into the arteries and having a look at them. So it was quite an invasive sort of procedure, and as you'll see shortly, there's been a huge change with the development of the MRI Scan. Clot-busting medications have come in, and at the moment about 5% of the patients that it could be used on get it in New Zealand, and we should be aiming at around, well, probably up to about 15%, because this needs to be given within 3 hours. So it needs patient awareness of the situation, the availability of CT scanning, and appropriate doctors. However, the great thing is, over the years, when I started in practice, I would see quite a number of, particularly men in their 40s and 50s, most of whom either smoked or had smoked. A lot of them had high blood pressure, and they had terrible atheroma, and they died with strokes and coronary artery disease. Now, that, I just haven't seen those sort of patients in the past few years, and I think that is largely due to the treatment of hypertension, cessation of smoking, and the control of cholesterol and, to a less extent, diabetes. But with an ageing population, there's inevitably going to be more stroke, and it still presents a major problem. And I think it's not the matter of lack of information, it's the lack of ability to change the underlying atheroma that's a problem with stroke. Now, from the patient's point of view, the most impressive thing for me has been the advent of MR scanning, and I'm just going to show you what these, the names of these mean. CT, or computerized tomographic. A tomogram's just a cut. So computerized, when it came out, this was 1968, anything with computer in it was really right up to the minute. So it was called computerized tomographic scans of the head, and I'll only show one of these. It has relevance today in that it's very good at showing up bone, air, and blood. Now, a head injury gives you all those three things inside the head. So CT scanning, very good in head injuries. Can do other things as well. PET scanning, positron emission tomography, was something that started in the 1960s, and we felt that it was going to give a whole new insight into how the brain worked. But that hasn't been the case, and there's no place for PET scanning in clinical neurology, with the exception that it shows up secondary tumours in various cancers. But ordinary clinical neurology, PET scanning has no value. But I'll show you a PET scan because it's a very pretty picture. This is a scan of a normal person and a person with Parkinson's disease. This is the front and the back, and it's as though the patient's been cut through the head. They've been given an injection of L-DOPA, which gets into the brain cells that are involved in Parkinson's disease. And the DOPA has been labelled with a radioactive fluorine. And the radioactive fluorine breaks down and gives off the positrons, and the positrons are then picked up by a scanner. So very complicated. You need a cyclotron, you need all sorts of things. Complicated procedure. And here's normal with white showing up these areas of the nerve cells that are affected in Parkinson's disease. Huge amount of uptake of L-DOPA in those cells. And then in Parkinson's disease, see the area is restricted and the intensity of the uptake is severely reduced. Now, it's technically possible to do this as a diagnostic procedure, but it's just not useful or practical. Now we move into MR scans, and MR is magnetic resonance, and I show you this just as a start, and this is a cut that goes through the orbits, obviously, and bridge of the nose, one eye with the lens in the eye, and the fluid behind the eye. This black is the wall of the eyeball. Here's the nerve behind the eye, and here's a muscle that moves the eyeball, and that's fat. And then as we move back, this is inside the head, and this is the temporal lobe of the brain, and you can see very nicely, there's the cortex in sort of rather white, and right in the middle is spinal fluid, cerebrospinal fluid, and it goes around the surface. So this is the convolution of the brain, and you can see perfectly well the difference between the grey matter or the cortex, which contains the nerve cells, and the white matter, the darker part, which is nerve fibres. And you can see all sorts of details. That's an artery that's cut across in cross-section. And then as we move from that, we go and look at the veins, and this is a special technique. And here's the nose here, front of the head, back of the head, and the veins over the surface of the brain, all these veins go upwards, and the blood goes then backwards there, and the blood from the inside of the brain comes in here, and goes in here, down here, and there. So this is a way in which you can diagnose thrombosis of the veins of the inside the skull, which we had great difficulty with before. When I was started, the techniques of investigation of the nervous system were to inject the arteries, put a needle into the carotid artery and inject dye into it, which people described as like having molten lead poured over the side of the head. Or we could do a lumbar puncture and put air inside and bubble it up inside the head, and when it got in there inside the head, it caused terrible headache and vomiting. And then, having done that, you spun the patient upside down, you tilted the air through all the spaces in the head so that you could see where things were. And of course, you still couldn't see the brain. And the other technique was to inject dye to look for a lumbar disc, for a simple thing like that. You put dye into the spinal fluid and ran the dye up and down. So these were all inpatient procedures, horrible things. And so when I started in 1972, there we were, there were 4 neurologists, and we had 22 neurological beds. Now there are 15 neurologists, 4 times as many neurologists, and they have 12 beds, half as many. So neurology, with the MR scanning, not only does a patient not have pain or suffering, which is huge, but neurology has become a largely outpatient procedure with huge savings in one way, but you've just got to remember that to set up an MR scanner is about $3 million. Then we've done the veins. Now we can, with the MR scan, we can also look at the arteries. And this is about the base of the brain here, and here's the carotid artery coming up here and up there, and then it divides there, and here's the middle cerebral artery, and it goes on to supply most of the thinking part of the brain. Now, a later slide will show you a middle cerebral artery, so I want you to remember this sort of pattern. The middle cerebral artery is going across there, and in any slide, always look at the arrow. The radiologists are very good at putting arrows in. So there is a little blowout or an aneurysm on the arterial wall. Now we can show arteries anywhere, and this is the neck coming down over the shoulders on each side, and there's the artery that goes to the arm. Here's the common carotid, and here's the internal carotid artery that I showed you on the other slide. Now, one of the techniques that I think is really remarkable is we now have interventional radiologists that can put Winkle catheters up from the groin, and it's got to come up from the groin about where my feet are, through the aorta, the main artery, up through common carotid artery, into the internal carotid artery, and up the internal carotid artery, round the corner, and they can get it into the neck of that aneurysm. What's the point in getting it there? Well, they've got these catheters, it's got a little platinum wire right on the end, and they can just give a zap, and a little coil of platinum wire is left in the aneurysm. And with the appropriate number of coils, and if there's a neck there, patient's cured. No big wounds, no open the head and all that drama. So this is the advantage of really the technology that goes with the space age. So that's really remarkable to me that anyone can do that, and they can now put catheters up and retrieve clots from these places. So, well, whether that's going to be a good thing or not is yet to be shown. Now, here's the sort of thing that we can see in the management of stroke. This is all the one patient, and these are 3 different types of MR scans that were done an hour and a half after the patient came into hospital, an hour and a half after the stroke, and before the clot-busting treatment. And here's the middle cerebral artery on this side. It's not quite as wobbly as the shake I'm showing there. And here it is on this side, and the arrow sign, it's blocked. And this shows the amount of blood flow, and you can see that it's reduced in the territory of that artery. And then another thing, which a different type, shows the actual cell damage, so the severe damage to the brain, and that shows up as a relatively small stroke. 5 days later, after the clot-busting treatment, the artery's normal, all this is returned to normal, and they're left with a small stroke. In fact, that patient had slight weakness of the right hand, was otherwise quite satisfactory. Now, the MR scan shows things that we just didn't know existed before. Here's a patient who lost the vision to the left side, and that's the front of the brain, back of the brain. Here's the skull, and the white is the fat of the scalp. Here's the brain itself, and this is the fluid inside the cavities of the brain, perfectly normal. White matter and grey matter. And at the back here is a very large area of white, and you can see it's abnormal, but it doesn't fit with anything. It doesn't look like a stroke or a tumour, and you can see that it affects both the grey matter and the white matter. And then with a special technique which shows up minute amounts of blood, patient's got lots and lots and lots of these micro hemorrhages, little bleeds in here, but also on the other side. And we now know that is due to amyloid, a substance infiltrating the arteries and then producing a huge area of inflammation. Amyloid angiopathy. We couldn't diagnose that, 15 years ago. And this is the only CT scan. Now it's a CT scan because here's the bone showing up white. Here's the dark, which is the fluid-filled spaces in the brain. And this is really reasonably good. You can see a difference between the grey matter, which is lighter colour, and the white matter. And that's all normal at the front. And at the back, you can see that there's something going wrong, and it looks as though it's in the white matter. And so the next thing, of course, is an MR scan. And this shows very beautifully that all the change is in the white matter. Look at the grey matter there with the normal sulcus. Grey matter is fine, white matter is involved, and this is a variant of multiple sclerosis. Now, the MR scan has been the investigation which has shown us so much about multiple sclerosis. Without the MR scan, we still wouldn't know all that much about it. It has been very important in determining all sorts of problems with multiple sclerosis. For the common things like back pain, of course, an MR scan is very good. And here's a normal disc, and down here you see the disc has been gone backwards, pressing on the nerve root, giving sciatica. So very quickly you've got an answer rather than having a myelogram with a lot of pain and a few complications. Now, finally, this is the last bit on the progress side. MR scans can show up the amount of oxygen in the blood, so that if, for example, you move a finger like that, that's the part of the brain that's involved, and the blood flow in that part of the brain increases. And if you've got a very strong scanner, which you can detect this difference reasonably well. And this is a composite that shows what happens between baseline and when someone, as example, hearing words, this is the left side of the brain, front, back, temporal lobe, frontal lobe, occipital lobe. So the hearing platform of the cortex is this part. Hearing words lights that part up. Seeing words, that's the part of the vision right at the back that actually sees it, but the comprehension of words is in this area. And these are both different. Speaking words, particularly this area here. So this sort of MR scan can show up which parts of the brain are active with particular brain activities. And as a measure of the importance of that, the psychology department of the University of Otago has been approved funds to get a dedicated MR scanner for functional magnetic resonance imaging, and that amounts to $6 million. So we now move into the last phase of the talk and the prospects. And I've already mentioned the prospects in the neurodegenerative disorders such as Alzheimer's disease. I'll mention each of these in turn. In Alzheimer's disease, we really want biomarkers, something that tells us that there's something going wrong with the brain before the patient's memory starts to get worse. And that's very difficult. Big ask, how do you do it? And we've got some markers in the spinal fluid that show abnormalities very early on, but we haven't got any test that we can do to say whether or not someone's got Alzheimer's disease. But that's the aim. And then the mechanisms involved, we've got a whole big handle on this. There's the genetics of it. In some particular forms of Alzheimer's disease, we know the genes involved and what they produce, but that doesn't apply to most of the patients with Alzheimer's. The amyloid, I've mentioned, the amyloid is central to Alzheimer's disease, and in the brain it changes from a soluble form of amyloid to insoluble amyloid that then folds and forms plates, and that damages the nerve cells, and we know the cascade of changes that that folding of amyloid can produce. And the amyloid can also infiltrate the blood vessels, and anything that reduces blood flow makes Alzheimer's disease worse. And in addition, I showed you that amyloid angiopathy patient with a whole sort of massive inflammatory change. So there are lots of changes that go on, and these can be influenced. Now we've got techniques that can influence them. And immune therapy is another big feature of progress in neurology. They are very expensive, they're targeted, they can produce an antibody to a absolutely specific protein. And these are the monoclonal antibodies, and again, you can hear a lot about those in the future. In stroke, generally, as I've said, it's not so much new information that's going to be important, it's the prevention. And the preventive measures are to some extent available for ordinary stroke at the moment. There's one group of disorders when the blood vessels that are involved are the very small blood vessels. Now, that is we just don't know what that's caused by. It's worse in patients with raised blood pressure and with diabetes. But that's going to be a whole field in which there's going to be further research and information. In epilepsy, I think it's going to be the information is going to come through genetics and molecular biology, and we'll be able to tailor the treatment to the specific type of epilepsy. So that I think is going to be where the change is going to be there. For brain injury, again, I think it's going to have treatment a bit like stroke. Need to treat the brain injury within the first hour and prevent all the secondary events like swelling and hemorrhages and all secondary changes, and prevent further brain damage occurring after the initial injury. And spinal cord grafting for spinal cord damage is showing surprising promise. I wouldn't have expected it on theoretical grounds, but it certainly does happen. So, in summary, you've been a fantastic audience. I haven't seen anyone with narcolepsy. The changes that I've seen over the 45 years have been amazing, and the rate of change has been much greater in the last 10 years than in the first 25 years. And that accelerating rate of change of knowledge is going to continue. And I'd be very happy to encourage any young medical student to go into neurology or to encourage a career in neuroscience. The future progress will need continued research, and New Zealand is at the forefront in a number of fields. And I have every confidence that with the research that we can continue and engender in the future is going to make a huge change over the next decade to the management of neurological disorders. And thank you very much for your attention.